My pleasure to introduce Dr. Britta Laslo, who is a graduate of the University of Ottawa with a Bachelor of Health Science, and then did her medical degree at McMaster, and graced us with her presence as a resident in family medicine and a PGY3 in academic family medicine, who's going to give her public lecture on transitions in medical education. Welcome.
Thank you. So, good afternoon, everyone, and thank you very much for coming today. I'd like to acknowledge my supervisors. You just heard from Dr. Thomas Freeman and Dr. Judith Bell-Brown, who's at the back of the room. Here's a brief outline of today's agenda, but without further delay, what is a transition? While the definition of a transition in medical education remains contested even amongst experts in the field, for the purpose of this thesis, the dynamic movement across different expectations, tasks, and responsibilities will be used to describe transition in the continuum of medical education. Before we further explore transitions in medical education, it's important to note foundational knowledge of transitional periods as described in identity psychology and industrial organizational psychology. Erik Erikson described the psychosocial crisis of identity versus identity diffusion as a major transition point in one's psychosocial development in late adolescence and early adulthood. Nigel Nicholson's work from Cornell University in the early 1980s theorized a social organizational process of transition, when individuals transition to a new work role. Lastly, Elizabeth Wolfe Morrison's work expanded on industrial organizational thought by looking at the role of the individual in workplace transitions. Unlike many others in her field, Wolfe Morrison viewed the individual as an active rather than passive player in work role transitions. As we transition back to the field of medical education, this schematic diagram is a visual representation of the trajectory of medical education for family medicine learners in Canada. There are three distinct transitions explored in the broader medical education transition literature: non-clinical to clinical medical student within the undergraduate medical degree, final year medical student to residency, which is the focus of this thesis, and finally resident to independent practitioner. Transition periods in medical education have unfortunately shown to be associated with personal negative consequences, such as stress, confusion, and uncertainty. The literature reveals that transitions are also associated with the development of unprofessional behaviors, such as lying about or withholding relevant patient information from preceptors. Transitions have also been shown to negatively affect patient care and are associated with adverse patient safety outcomes. When exploring the resident perspective on the transition from medical student to resident, residents feel intense competing emotions of excitement and fear surrounding their increased responsibility for patient care. Completing one's undergraduate medical degree in a problem-based learning, or PBL curriculum, having experience working in multidisciplinary teams, and possessing certain personality traits, such as extroversion, all seem to be protective factors against the stress and anxiety described by this population. Literature capturing the clinical preceptor perspective on working with learners in transition in their first year of residency describes a deep concern for residents' abilities to transfer academic knowledge to clinical care. Preceptors also note much difficulty in residents' abilities to manage complex patients and a lack of resident confidence in performing certain procedural skills. Looking at a Canadian family medicine perspective, which is important given the unique 2-year length of the family medicine residency program, 2 studies from Ontario begin to fill knowledge gaps around transitions for family medicine learners. A study from McMaster revealed the important impact of peers in the choice to practice comprehensive family medicine upon graduation. A recent study from the University of Toronto described the negative influence on residency demands on residents' personal relationships and overall wellness. Although these 2 studies are both insightful, there still remains a paucity of data exploring the specific transition which influenced the development of the study questions of this thesis. Moving on. This thesis is comprised of 2 studies exploring the transition from final year medical student to first year family medicine resident. I'll also be using the abbreviation FMR to describe family medicine resident. The first study question was, what are the feelings and experiences of clinical preceptors supervising family medicine residents during their transition from final year medical student to first year family medicine resident? The second study aimed to capture the family medicine resident perspective and asked, what are the feelings and experiences of first year family medicine residents about their transition from final year medical student to first year family medicine resident? Ethics approval was obtained through the Non-Medical Health Research Ethics Board at Western University. In terms of recruitment, all family medicine preceptors in the postgraduate department of family medicine were sent an email with an invitation to participate in the study. A potential list of participants was generated to ensure breadth of years in practice as well as geographic variety in practice setting. This was a purposive sampling strategy. For study 2, all FMRs enrolled in the family medicine postgraduate residency program were emailed an invitation to participate. Reminder emails were sent after the initial recruitment email at 2, 4, and 6 weeks. Participants were eligible for inclusion in study 1 if they were a current family medicine preceptor in the Department of Family Medicine at Western and had at least 1 year of family medicine preceptor experience. Participants were eligible for inclusion in study 2 if they were a current first-year family medicine resident and had completed their undergraduate medical degree at a Canadian medical institution. Qualitative description was the method of study design chosen for this thesis. 2 semi-structured interview guides, 1 for each study, were used during interviews which were conducted by 1 interviewer. Interviews were 25 to 45 minutes in length, audio taped and transcribed verbatim. The data analysis process incorporated iterative and interpretive analysis techniques with concurrent data analysis and data collection within and in between the 2 studies. Independent analysis was followed by team analysis where keywords were coded, reviewed, and emerging themes explored by the 3 researchers. This process occurred over an extended period of time to allow for deep immersion of the data and the organic development of themes. Saturation, also described by researchers as data sufficiency, was reached by the 8th and 7th interview in study 1 and 2 respectively. 2 additional interviews were then completed per study to ensure that no new themes or findings emerged. Trustworthiness and credibility of the data were enhanced by the following means. A methodology concurrent with the study questions was chosen and purpose of sampling of participants with intimate first-hand knowledge of the transition being explored were invited to participate. Audio taping of interviews allowed the interviewer to create field notes to capture emotional intensity, nonverbal body language, and to include questions for later reflection to supplement the data accuracy. Engaging in reflexivity was a process of reflecting on my own role as the researcher and how my own experience and research lens influenced and enriched the data. The final sample in study 1 included 10 family medicine preceptors. There is maximum variation in the total number of years teaching, gender, and practice location. The final sample in study 2 included 9 participants. There are 4 females and 5 males, ranging in age from 25 to 27. 2 participants were working in a rural or regional training site, and 7 in an urban setting. Moving on to the findings of study 1. 5 main important findings were discovered through data analysis. They are the learner-preceptor relationship, also referred to as the LPR, the importance of collegial relationships and mentorship, the value of one's own experiences with transition, preceptor feelings, and the evolving learner. I will review each of these findings separately. The learner-preceptor relationship was an important theme discovered in data analysis. Participants noted the importance of understanding residents as people, each with unique characteristics, experiences, and context which influence their transition. Preceptors noted that with deeper understanding of the resident as a whole person, they were able to more appropriately tailor their expectations and help tailor their teaching approach. This participant describes the value of learning about the resident as a person in developing this relationship. Getting to know who they are as people and understanding what's important in their lives, and being a little less rigid in my approach to academic tools, and a little bit more real personhood with the learner actually goes a lot further. The second finding explored is the importance of collegial relationships and mentorship. Participants described clinical peers and allied health colleagues as their main sources of teaching support for working with FMRs in transition. They also noted the lack of formal training or orientation for working with learners in transition. This next excerpt illustrates the importance of the relationship with clinical peers. So regular meetings with colleagues, serves as a forum to brainstorm and clarify ideas about teaching. That little community is really important to me as it influences how I do things. In the third finding, preceptors noted the value of past experiences with transition in their personal and professional lives when working with FMRs. Experiences varied from geographical moves to changing one's profession and even immigration. The experience of immigration is described here. I'm a first-generation immigrant and an international medical graduate as well. Having been through the system makes me more aware of those challenges that are faced by young people. It makes you more aware of what's out there and how they respond to stresses. Conversely, this participant explored the effect of having completed all undergraduate and postgraduate medical education at the same institution and states, to some extent, my own experience kind of limits my ability because I didn't have to transition to another location, which I think adds a lot of complexity to the transition. I have to remind myself that most of my learners are coming here for the first time, so it's more challenging than what I went through. In the fourth theme, the main feeling expressed by all participants about supervising FMRs during this transition was predominantly a positive one. Nevertheless, preceptors also described competing feelings of frustration when working with time constraints or when residents lacked insight into their own struggles with the transition. This preceptor describes the overall positive experience. While the experience has been great, rewarding for myself, it's been educational, it's been entertaining, it's been challenging at times, fulfilling. Oh boy, there's so many ways to describe it. Overall enjoyable, let's put it that way. On the other hand, the following quote illustrates preceptor frustration. You see similar themes come up during the transition period, and you're dealing with the same types of situations. The frustration really sets in when the person doesn't understand or doesn't get what's happening. The fifth major theme discovered was that of the evolving learner. This theme is comprised of 4 sub-themes, which will be reviewed separately. Participants identified a generational shift in learners and noted resident concerns around managing stress and achieving work-life balance. Participants noted that demands on residents seem to have increased as many more residents have families and children, which undoubtedly necessitates careful work-life balance during residency. This participant noted the change in life stage of learners. There seems to be a lot more people in medical school and residency who are married and have kids, and their family lives are more prominent. The use of technology impacted participants differently based on their total number of years teaching practice. For participants with greater than 5 years of practice experience, they noted the need to coach learners to appropriately navigate technology in the context of family medicine interactions. This is illustrated in the following quote. It gives them more confidence since they can look up the answer. The information is there, but they still need some guidance. Listening to patients, not looking at the computer screen when you're talking to patients. Just shut up and listen to people. So it's a mixed blessing. It can really help, but it can also take away from the very personal aspects of family medicine. Participants also conveyed concern about their inability to effectively assess and help learners when working with a learner in transition and difficulty. This is articulated in the following quote. So the worry in that is when people aren't doing so well, it takes up a lot of time, and that just adds to some of the stress. There's a tendency just to let things cruise along, and I think maybe that's why sometimes things just come to a crisis. In the fourth and final subtheme of the evolving learner, participants expressed their concern with systemic gaps that hinder the ability of residents to succeed in their transition. These gaps were noted at both departmental and institutional levels. The above participant notes, the system doesn't manage the transitions or support residents while in transitions. Our system has never really responded to the needs of trainees in a transition period. There are 5 key findings that emerged in this study that offer the following conclusions. The importance of a learner-centered approach to transition and teaching is key to strengthen the learner-preceptor relationship and acknowledge the learner as a whole person. Continued opportunities for preceptor mentorship and collegial collaboration are paramount to support preceptors working with this population. Formal support and training for clinical preceptors is absent and critical to develop teaching skills specific to the learner in transition and to meet Canadian accreditation standards of residency teaching. The above would be best supported by a larger institutional shift in how our institution recognizes the learner in transition and their unique needs. Moving on to the findings of Study 2. There are 5 key findings that emerge from data analysis. I will review them separately, and they are listed above. Participants overwhelmingly described their transition experience as positive. While many participants articulated how the increased responsibility and steep learning curve added complexity to the transition, the dominant description of this experience remained as positive and rewarding. The support from peers and near peers who are also going through or who had recently experienced this transition was noted as validating and crucial in ensuring a positive transition experience. This example illustrates the aforementioned finding. The transition has both been challenging and a daunting experience, but also hugely fulfilling and necessary in transitioning to becoming an independent practitioner after the 2 years of residency. This participant explored the complexities of the experience through a shared inner dialogue. There was a lot of anxiety in terms of, is this the right medication? Is this my scope of practice? Should I be doing this? Should I ask for help? So it was kind of hard to navigate my role at that point. There was a certain amount of discomfort in being able to trust in my own abilities. The following quote describes the validating support of peers during the transition. Definitely my peers, other residents. We talk about the shared experience of adjusting to residency, so that's kind of helpful to say, okay, I'm not the only one to experience these kind of feelings. The second overarching theme explored feelings and experienced by participants. A variety of feelings were described, which evolved and were also in competition throughout this transition. This participant describes the evolution of his feelings as follows. When I wrote my first prescription, I freaked out. It was challenging to know that the safeguards were removed a little bit, and I had to rely on myself more than on others. But it's a sense of ownership taking care of my patients, and there's a greater responsibility towards my patients now, and that's rewarding. This excerpt illustrates ongoing anxiety throughout the transition. I think it is persisting throughout my residency. I'm afraid of making bad decisions to negatively impact the patient. I've gained some confidence and I've progressed as a resident, but I would say it's still there. The third finding of the study revealed a major professional change that occurred early in the transition. Participants noted an increased sense of duty and responsibility for patient care, which motivated them to adapt their learning styles to best care for patients. This resident describes the change as follows. So definitely, that's been a huge shift in learning to do well in school versus learning to actually do the job, to be a good doctor. I would say it was totally intrinsically driven. In the fourth finding, participants described personal attributes or habits as intrinsic factors influencing their transition. Extrinsic factors were more diverse and included geographical moves, past experiences with transition, and residency rotation schedule, to name but a few. This participant describes personal attributes that assisted him through the transition, as well as external influencers who provided support. I'm logical and organized and recognize what I need to support my transition, and I can reach out to family, friends, and others who are in residency too. The next participant shared the intense experience of losing a close family member and how that loss has affected all future transitions. It made every transition after that much more difficult. With any big change, finishing medical school, starting residency, every big change tainted by the fact that I didn't have that support person to help me. I continue to think about that with every transition that I have. The final theme emerging from the analysis was a consistently articulated feeling of being disconnected from the family medicine program. This feeling was described with a noteworthy degree of emotion. The lack of connection was experienced most acutely when participants started on an off-service rotation. the following quote describes this lack of connection. I remember when I started feeling a little bit adrift and very off service because we didn't really do anything that was consolidating. I have friends who don't transition to family until next block, and I think they feel a little bit more lonely. Another participant described discomfort around not recognizing peers in the same cohort and not seeing familiar faces on off-service rotations. It bothers me sometimes not knowing everyone in the room. I think about running into someone in 5 years and only then realizing we are in the same program. It seems bizarre. There are 5 main findings of this study. The 5 main findings of this study reveal that FMRs describe a positive, complex experience with competing emotions during this transition. The study found that peers and near peers to be extremely important in validating and supporting the transition experience. We would hypothesize that more formalized mentorship opportunities among near peers as helpful to enhance a positive transition. Early clinical connections to family medicine preceptors and the Department of Family Medicine is key to facilitate a feeling of connection amongst residents with family medicine supports and professional role models. As the findings reveal the multitude of extrinsic and intrinsic influencers on transition, it is important to understand the learner as a whole person. Moving on to the limitations of this thesis. Generalizability of the findings would likely not be appropriate across other Canadian family medicine programs or in an international context, given local and contextual variability and how the postgraduate curriculum is organized and delivered. There may also be a self-selection bias of participants who have had a more positive experience with transition to have chosen to participate in either study. The age of FMRs in Study 2 was very homogeneous, and further studies could look to include older learners. Study 2 also lacked an international medical graduate perspective, which would be important to include in further studies to be truly representative of all medical learners who experience this transition. I will lastly review some shared themes and differences among Study 1 and Study 2. Additionally, proposed next steps to integrate and explore notable findings from this thesis are suggested. While both groups of participants described the transition experience as positive, both experienced negative emotions as well, largely frustration for preceptors and anxiety for residents. There should be discussion amongst preceptors and residents to ensure an awareness of these emotions and their impact on learning throughout the transition. We would hypothesize that this may lead to less preceptor frustration and in turn could increase confidence and decrease anxiety amongst learners. Training preceptors in methods of learner-centered teaching could help preceptors understand resident-specific contexts and experiences, which could further enhance the learning relationship and the transition experience in both groups. The important influence of relationships was a notable finding in both studies. Preceptors described the valuable support and guidance from physician peers and allied health colleagues, while residents described the importance of a supportive and validating relationship with peers and near peers. Enhanced opportunities for collegial collaboration when working with learners in transition, and the creation of formalized mentorship programs for preceptors and learners alike could strengthen the positive impact of these relationships. Preceptor shared a consistent message of lack of formal teacher training with focused attention to working with the learner in transition and the learner in transition in difficulty. As a Canadian postgraduate accreditation standard, a review of faculty development, orientation, and current programming should be completed. Furthermore, as preceptors describe the various time pressures placed on them, the department should explore the creation of a formal academic support committee to work with learners in difficulty as well as their preceptors. With increased supports, we would hypothesize a continued strong legacy of family medicine learners and preceptors in the Department of Family Medicine at Western University. I'd like to thank you for your time and would open the floor to any questions. Stack of paper away.
Britta, thanks
Yes.
very much. Very interesting talk.
Thank you.
I appreciated your attention on faculty development, specifically around the issues that you found.
Yes.
I didn't see, or maybe I missed it, but I didn't see in your studies anything that had mentioned role modeling.
Mm-hmm.
And I wondered if if you thought that came up somewhere and how it might influence your findings.
Yes, so there definitely was some discussion amongst role modeling, or about role modeling. I really, given the brevity of the presentation, I couldn't include that. But there was a lot of discussion about informal mentorship and role modeling, but more importantly, participants noted the lack of formal mentorship and formal role modeling. So they really noted that as lacking in their experience as teachers, especially young teachers. So it was there. It just wasn't a prominent theme. Unfortunately, it was kind of shadowed by this lack of teacher training. Does that answer your question, Dr. Whitmore?
Yes, it does. I guess as a veteran preceptor, we tend to think that sometimes I think that learners will pick that up as they go along through their residency by watching or mimicking what we do as preceptors, and as I say, I just didn't see that as strongly in your findings, which is interesting in itself. I maybe misunderstood your question. I thought you were talking about role modeling with junior faculty and senior faculty. You meant between learners and their preceptors? I was thinking more between learners and preceptors. So learners actually found role modeling with their near peers to be far more important in their transition experience. And that was one of the differences between the two studies, that supervisors really, again, looked to their clinical colleagues and looked at the importance of the learner-preceptor relationship, whereas learners or residents looked to their peers or near peers and didn't, at least in the transition time, they don't describe the relationship with their preceptor as being that close. As you could see in the last finding, they actually feel quite disconnected. Yeah. Thank you.
Yes?
The focus, obviously, on family medicine residency, but I'm wondering what you think might be the applicability to other transitions in medicine, to other types of residency, and indeed to other professional transitions, other types of professions, dentistry or like field clinical psychology.
So interestingly, in medical education, we are far behind at looking at transitions. As I alluded to in the literature review, we look at psychosocial transitions and industrial organizational transitions, and the business and psychology literature is robust. But this is still new since probably the early 2000s that medicine has been looking at transitions in medical education. Some of the other residency programs have more formal transition series in my review. We have, as part of our postgraduate medical education, a formal transition series for all residents transitioning into residency. But again, as noted, family medicine is so unique because it's only 2 years. So I'm not sure that these findings could be generalizable to other disciplines, although I'm sure that it should be further explored to see if it would be applicable amongst other residency programs and other disciplines. I think, again, the importance of relationships was really highlighted here.
Some things may be unique, but other things may be more
universal. Yeah. Thank you.
That's all the time we have for questions right now. Dr. Laslo will now meet with the thesis examiners, and so we'd ask you to vacate this room.